Okay, hello everyone and welcome to Global Medical Education CPD webinar series. My name is Professor Naseem Naqvi. I'm a consultant stroke physician in Blackpool, Cumbria and Lancashire Stroke Network. And I have with me the program organizer, Dr. Mansoor Ali, who is a consultant a nephrologist from Bradford. Thank you very much for joining us on Sunday. We have two excellent speakers. In fact, I would say thought leaders in the field of respiratory medicine. And I would like to introduce Dr. Aziz first, Dr. Imran Aziz, our first speaker, whom I've known since all the way back to 2005, when I started my first clinical job in the NHS at Wigan Infirmary, which is a hospital in the northwest of England. And he has been an excellent friend, colleague, and extremely supportive throughout my career. And we regularly meet as well at meetings and forums. And also recently, I happened to be examining for FRCP, and he was the host and chair there. So, and he has regularly attended our forums for the past 4 or 5 years. He is there in almost all forums. And I'm very delighted to welcome him today. And he's going to talk about a very interesting topic, green inhalers in asthma, and the carbon footprint of inhalers. So I'm very much looking forward to his talk. And thank you, Dr. Aziz. Over to you. Thank you.
Right. Thank you, Naseem. Can somebody just say that or raise your hand to say that you can see my presentation?
Yeah, we can see. Yeah.
Yeah. Okay. Right. So I'm going to talk about green and greener inhalers, which is something quite in at this moment in the NHS. I'll explain later, but as you can see that I am the airways lead, so I do both asthma as well as COPD, so wherever inhalers are used. So my first slide is not about the green inhalers. It is just to tell everybody that actually COPD is a very major problem. It costs a lot of money, as you can see, and it is the third leading cause of death in the world. And actually, of all the top 10 leading causes of death, it is the only one which is still increasing. All others have started to go down, but COPD is the only one where we are still increasing. So it's a bit something to worry about. And one last slide about COPD. Now, can you all raise your hands if you think you have done an exertion which will make 50% of people short of breath today? Have you done any exercise, exertion today, which you feel that the people might be short of breath after that?
Yes.
Okay, so you are active. What did you do?
So just this morning, I just did some treadmill, Dr. Aziz, in the gym for about 10 minutes.
Well, I have a feeling that there are 25 people in this forum, and all 25 have done that exertion. And that exertion is that everybody got rest. So half of people, almost 40 to 50% of COPD, severe COPD patients become short of breath by just getting rest. And I'm sure no one ever thinks about getting rest as doing an exertion. So it is a disease, not only that it costs a lot of money, it is increasing mortality over time, but it is the one which has one of the most poorest quality of life amongst all diseases. So we'll talk about COPD at this point. There's a little bit of COPD later on, but that's more to do with inhalers. Right. So this flag is the flag of Croatia, which you know is a country in the Balkans, about 60,000 square kilometers, about 4 million population, and it has a GDP. It's not a poor country. It's in the top half of the world. Out of the 190 odd countries, I think it's around 80-ish mark. So it's not a poor country, but did you know that the carbon footprint of NHS is equivalent to the country of Croatia? We spend so much carbon releasing activities, we take part in those, that it has become quite important that we should, if we are going to cut down on global carbon emissions, then NHS has to play a very important part in it. So we are going to talk mainly about inhalers, and there are three main types of inhalers. The meter dose inhalers or pressurized meter dose inhalers came out in 1950s. The first dry powder devices came out in 1980s, and around the noughties, the soft mist devices came out. So there are only three main types of inhalers. Obviously, everybody does see that there are things called nebulizers, but nebulizers have been there actually on something equivalent to the first nebulizer is about 200 years old. But as far as we are concerned, we are talking mainly about inhalers. And so the important thing to remember is that inhalers are quite important in producing the carbon footprint, right? So why are we worried about all these inhalers? So in 1986, there was a Montreal Protocol because research had shown that the CFC, chlorofluorocarbons, which were present in the in the inhalers, were damaging the ozone layer in the world. And as you know, ozone layer protects us from the sun rays and the harmful effects of sun rays. So the Montreal Protocol came out, and the Montreal Protocol was that we should move away from CFC usage. And so in theory, there were three choices left. The first choice was to make a CFC-free inhalers. And for that, rather than using CFC gas, most of the inhalers now have hydroxyfluoroalkanes in gas to be used as a propellant. Or they could spend extra money, more research, and use a dry powder device. And there was an option 3 as well, that they did allow the companies which still had stores of CFC gas to still use it in, till they finished. And at that time, apparently in America, after heroin, CFC gas was the highest smuggled narcotic or medicine which came into America, because big companies suddenly found big stockpiles of CFC gas because China and India were exempted from the protocol initially. But anyway, that's just. So this has led to everybody developing different inhalers and then generic inhalers, etc. So there are 140 different inhalers which are available. And why are we so concerned about it is obviously we are talking about climate change, global warming, the melting of the Antarctic ice cap, which everybody talks about Extinction Rebellion, but actually the UN conference on climate change preceded it by 10 years. But then came Donald Trump, and we got a bit of setback after that. But anyway, so climate change is very important. We have to make sure that we leave this world for our children to live in afterwards. So as you can see, that this is a screenshot from a website called greeninhaler.org, and you know, a CFC free inhaler salbutamol is equivalent to driving 175 miles, which is roughly between London to Sheffield. But a lot of us are from Pakistan, so I have just put in that you can drive from Rawalpindi to Lahore by using one inhaler. We talk about the inhaler from the time it's formed, the gas it contains, and it's disposed of, and if that gas goes into the atmosphere, how much does it cost in a medium-sized car driven from one place to another. While if we use a dry powder device, it's only 4 miles. So there's a big 170 miles difference between an MDI salbutamol and a dry powder salbutamol made by the same company, Glaxo, right? So a lot of my talk is going to be based on the GMMG, Greater Manchester Medicine Management Group, and they have made guidelines. So the reason I'm talking about in detail about these guidelines, which yeah, although you're going to talk, say that I was supposed to talk about green inhalers, and I'm talking about GMMG. But amongst all the various regions of the country, people have started making different guidelines, which are slightly different from NICE and the BTS guidelines, because they are most probably updated more rapidly. The NICE guidelines the last came out around 2016, and they are in the process of being updated. And the BTS guidelines were even before that. They do have little bit updates regularly, but the new guidelines do not come out for a long, long time. And during that time, a lot of things change. So I'm going to show you the GMMG pathway. So GMMG pathway is based on two different parts. One based on the green pathway, which as you can see, and there's a pink pathway as well, which is or red pathway, which is with MDI. So the first pathway is with the dry powder devices. So it's following on from the NICE guidelines, but it is based on a dry powder as the first choice. Because as you can see, these guidelines also have this big advantage that it gives you roughly the carbon footprint of each inhaler device based on as if it was a car and a medium-sized car, and how many miles it will have to drive to get to the same level of carbon footprint. And not only that GMMG has made the asthma pathway, they have also made the COPD pathway in a similar way, dry powder based pathway. And the dry powder pathway is a lot better than the MDI pathway, which has a very high carbon footprint. And when we are looking at carbon footprint of these inhalers, again, there's the COPD pathway as well and the asthma pathway. So just to show that roughly 250 miles with the 40 miles, and it's the same drugs, delivery is the same. The drug company which makes these, they claim the same carbon footprint for each and every, same lung delivery for both types of inhalers. So it is quite astonishing. Even when I got this data, and this is not my data, this data, as you can see, I've given the link to where you can see all the inhalers and the data of the carbon footprint of each one of them, which was calculated on the data that was given by the manufacturing company to the to the government, and it is open knowledge, and you can find out whichever inhalers are being used. And so now coming back to the reason for all of this is that, as I had mentioned earlier, that the carbon footprint of NHS is equivalent to the country of Croatia, a 4 million people country, and 13% of the carbon footprint of NHS is basically inhalers or gases that we use. That is a very, very high carbon footprint for one company, and out of that one company, 13% is a big number, because obviously there is a certain amount of carbon footprint which is NHS related, which most probably we can't get rid of because everybody has to go to work, the patients have to come to the hospital have to be warmed up, etc. But we can definitely work on decreasing the inhalers by just doing changing from the inhalers to a dry powder device. We can convert into or decrease it by 80% the carbon footprint. And the 1996 is not a protocol. That is the first time I actually decided that I am going to use a dry powder device as my default. And I am using a dry powder device from that time onwards. Although I will raise my hands, it was not due to the global warming. I'll be quite honest, I knew that there's a thing called global warming in 1996, but it was because I actually got myself tested on an MDI training device and I failed. And I decided that if I can't learn this, it's better to use a different type of inhaler. And my different type of inhaler was to use a dry powder devices. So I became a dry powder person from that time onwards. Now, a lot of you are going to think about that, but the people, it's very difficult to teach people how to use an MDI and how to use a dry powder device. People will not have the sufficient inspiratory flow to use a dry powder device because the dry powder devices require more inspiratory effort than an MDI. All I can say is that Jamson and Thoracic 2 years ago presented data about Sweden and England. And as you can see, that England, in 94% of inhalers were MDIs, and in Sweden, only 10% were MDIs, right? So, and that's of a short-acting beta agonist, but it's the similar data that Sweden, for example, has such low MDI usage. So they don't use gases, they use dry powders, and they, and a lot of people say it's difficult to teach. And I'm only going to say one thing. Do you think that the stupid people living in Sweden are more intelligent than the stupid people living in England? I think I'm sorry to use the word, they're both equally stupid. So the person who's stupid is the healthcare professional who does not spend time to teach their MDI training device to their patients versus dry powder devices to their patients. Because we repeatedly find that the patients have been given inhalers and they were never taught how to use them. And people have been using them incorrectly. And if they're given a spacer, then they're incorrectly cleaning the spacer, wiping them clean, washing them in cold water, all of these things. So we don't spend time. It's nothing to do with the inhalers. It is to do with the people who are teaching. And I think I'll stop here. I think I've got to 20 minutes.
Thank you very much, Dr. Aziz. Excellent presentation, very enlightening. We have some questions also. Mansoor, shall we take one question now and then later?
Yeah, I think we should actually.
Yeah.
Do you want to? Shall I ask the question?
Yes, please.
That's okay. Thank you. Thanks a lot, Dr. Aziz. Really enlightening, actually, for people, for all of us, actually, who don't do green sort of practice in medicine as such. So there's a question from one of the attendees, Sureka Jani, who actually says, I'm working in Milton Keynes Hospital, working part-time after retirement as associate specialist in anesthesia. My question is, what is the cost implementation using dry compared to routine inhalers? So Sureka is asking about the cost implementation using dry compared the routine inhalers.
Right. Now, the one that I showed you, the picture of the Foster, the MDI versus the dry powder device, the cost is exactly the same, right? Although overall, the dry powder devices are slightly more expensive, but they are coming down. Previously, the difference was quite a lot. Now, the only difference between the cost of inhalers in between dry powder, where it is significant, is in salbutamol or the short-acting beta agonist, where the dry powder device is about two to 2.5 times more expensive. But otherwise, all of these devices which are dry powder are about the same cost, maybe within 10%. But as I said, salbutamol is the only one where the cost is different, but I'm sure it will change over time.
Thank you. Well explained. Thank you very much. Another question from Prof. Naqvi before we move on to the keynote speaker. The question from Professor Naqvi is, what is it actually exactly that's harmful to the environment when you talk about these inhalers? Is it the drug itself? Is it the plastics? Or the production, basically the methods used in production, including carbon dioxide, that is harmful to the environment? Thank you.
It is the actually propellant. So in the canister, there is the drug. The drug is, and there is a propellant, a gas that pushes it in. That propellant has the global warming because that propellant is a greenhouse gas. So it sits on the top of our world's atmosphere, and when the Earth, when it gets heated up, it reflects heat into the universe, as you might call it, and it stops it. So it is the propellant which is the different, because obviously the plastic used, etc., are somewhat similar in all of them. So when we are giving you this mileage, it does take into account how much does it take to dispose of these inhalers as well. And before I finish, the people who are living in this country and they are going to use, give it to their patients, for them, may I just suggest that they should also tell their patients that once the inhaler is empty, do not dispose of in their garbage. Take it back to the pharmacy, who will dispose it off in a more scientific way. And that will also help, because although the inhaler drug might have finished, the propellant might still be there. So when they feel the inhaler is empty, take it back to the pharmacy. Do not dispose it off in the garbage. Thanks.
Really,
I will turn myself off now and leave Alyn.
yeah,
thank you very much. Dr. Aziz. So our next speaker is our keynote speaker. We are delighted to have Professor Morice with us today. Very honored, very grateful for him to accept our invitation. And Professor Morice needs no introduction. He is a professor of respiratory medicine at Hull York Medical School in the UK. He's also the head of cardiovascular respiratory studies and really national and international authority on the topic of cough. He's written hundreds of research papers and also led the Respiratory Society task forces on cough. And he's going to talk to us about what's new in the diagnosis and management of cough. Thank you.
Hello, everybody. Can you see my screen? I'm
yes
sharing it. Yes.
Yeah.
Yeah. Good. Okay, cough. So a lady comes along to you and she's had a cough for, a year or so. And it keeps on coming back and there's exacerbations and she's been given antibiotics, because of their chest infections. But it keeps on coming back. So what's the diagnosis? The diagnosis is that this lady has a chronic cough. Chronic cough is a disease, right? It's not another disease. It's not asthma or COPD or any of the other respiratory disease. It is a disease in its own right. Chronic cough is a disease of vagal hypersensitivity. Sorry, no, we don't want that one. Right, so it's a hypersensitivity of the vagus nerve. We need a cough reflex in order to stop things going down the wrong way. Right? It's a vitally important protective reflex. But some people develop a hypersensitivity of this nerve reflex, and they exhibit it. You can talk to them and ask them about what sets them off, and they'll say strong smells, bleaches, perfumes, the change in temperature, going out on a cold day, that makes them cough because the nerves have become hypersensitive. Right? And on the right there, you can see that I showed this in 1987, right? And this is ACE inhibitors making you cough more. So ACE inhibitors don't make you cough, but they increase the sensitivity of the vagus nerve to stopping substance P. Anyway, so we have a system here which is very protective, but when it gets overstimulated, it causes problems. Let me just next. So what is the demographic of these people who come and see me in my cough clinic? Well, they're predominantly women. 2/3 of them are women, and mainly middle-aged women. But there are men there too, and even children. So this disease of chronic cough, this hypersensitivity of the nerves, is mainly in middle-aged ladies. As I say, it's not exclusive. Other people, children get it. But there are associations like irritable bowel syndrome. I think this is a disease of the guts mainly, and obesity, neuropathic syndrome as well. It goes. There are many different aspects to it. So why women? And well, you feel the cough up here, and fMRI shows the activity of the brain when they're coughing or just about to cough. And it's in the somatosensory cortex here. And when they've looked at this, women have twice the size of activation of men, right? Women have evolved a hypersensitive cough reflex, and that, I think, is to protect them against reflux and aspiration during pregnancy, right? So that's why I think women's brains are different from men. I don't want to be controversial here, but it's true, right? So women's brains have had a higher sensitivity to cough stimuli here. Right. Normally the brakes are left on here, so the area here inhibits coughing. So when that pathway is defective, then you can give drugs which will inhibit the cough. So here I've shown in this study that opiates suppress cough, right? And suppressing cough it works in about 1/3 of patients. So it's not in every patient. About 1/3 of patients, you'll give them some morphine, and wow, this is fantastic. Low dose morphine, 5 milligrams twice a day. It's like turning off a switch, doctor. It's a miracle. Only in a third of patients. And this is not a new idea. This is the original inhaler, the very first developed inhaler. It's by John Mudge, right? And he was the astronomer royal, right? And the inventor of telescope. And what did they try in their inhaler? It was opium, okay? Opium to suppress a catarrhous cough. I got one of these. It's on my desk at work, right? And opium was used in this original inhaler. So I've said the central mechanisms, but out on the outside, in the airways, we've also got peripheral irritant receptors which tell us to cough. But what's in the diagnosis, right? It's diagnosis of airways disease is a mess. We use physiology, i.e. spirometry or peak flow or anything else, and that's nonsense. What we need to understand is the pathology of the disease. And in cough, it's a unique thing because cough is, a nervous disease, really, nervous disease of the lung. It's not like in asthma or whatever, bronchial constriction. It's the nerves that go. So we have this paradigm where we have COPD, which I don't understand. Frankly, COPD, they defined it on FBPhs. It's emphysema. Emphysema is lung destruction, whereas in chronic bronchitis, right, there's lots of phlegm and the lungs are relatively normal size. These are not the same diseases. It's not a disease of COPD, right? There's airflow obstruction. And then we have asthma, which is variable, but, what we have is this disease of cough. And we can put that on top of it. So this is a disease which actually disrupts the paradigm that we are so used to of FEV1 below 80% equals COPD. It's bronchitis with perhaps irritation of the nerves. We need to think about the etiology. And this disease is called all kinds of things. Idiopathic cough, bronchitis, the refractory chronic cough, and asthmatic cough, and reflux. But what we've got is a situation like this. This is an ancient Indian tale of the 6 blind men who go and see an elephant. Right? And when they go and see the elephant, the guy at the front, who's the ENT surgeon, he feels the trunk. And he thinks it's a snake, and the guy here by the side feels the side of the elephant, and he thinks it's a wall. And the guy feels the leg, thinks it's a tree trunk. So we're seeing the same bit of pathology, but different specialities are looking at it a different way. So there is no doubt that reflux has an important role in cough. Reflux is not just acid reflux. It's esophageal dysmotility as well. And that irritates the nerve, the vagus nerve, which controls both the gullet and the lung sensation. So if you have a poor swallow, and it sticks there, it might well give you the sensation that you need to cough it up. Right? So if you look on the right-hand side there's a normal swallow, right? And the swallow goes down, but on the left, there's an abnormal swallow. In the middle there has been no contraction. Right? And so that person has left their liquid in their esophagus, and you can see that by the purple line that continues across. The following swallow, the good swallow, then produces a appearance of this. So this person has had irritation of the esophagus caused by this liquid, water in this case, sitting there, and perhaps it causes reflux, non-acid reflux. Doesn't reach the stomach, so there's no reason for it to be acid. And then that irritates the vagus nerve. So what we have is, unlike asthma, unlike COPD, we actually measure cough, right? It's a real disease. We can measure it, and there is someone with a chronic cough. And I've measured this, and you can see it goes in bursts, doesn't it? Sometimes they are not coughing, mainly at night. And then when this person gets out of bed, young lady, I think, gets out of bed at 9:30, and you can see her coughing intensely right at the bottom there, and then it stops for a while, and then she has another bout of coughing. That's probably because she's had breakfast, and then she's not too bad. And you can actually see a pattern, and it's because of what we know about esophageal motility, esophageal physiology. And you can actually see it. This is a technique we've just introduced to our laboratory. This is from Australia, and these Australian guys have measured the reflux, and you can actually see it landing. This is non-acid gaseous or misty reflux, which lands on the larynx there, and there's the picture of it. And 75% of patients were female, i.e. fitting the group that we know about chronic cough, and the 96 of them had demonstrable extraesophageal reflux, and over the half of them it went into the lung, where of course it causes lung damage, even bronchiectasis, bronchitis. So how do you diagnose it? It's dead easy. Do this questionnaire. It's available on that website in a whole range of different languages, 70 I think was the last count. And basically this is to diagnose airway reflux, non-acid gaseous reflux, and what precipitates it. So getting out of bed. If you look out at esophageal manometry, it's completely flat until the patient gets out of bed, and then they reflexly open the lower esophageal sphincter. That's why they cough, as they get out of bed. Obviously, it's cough with food, and of course, the reflux lands on the vocal cords, causing a problem there. So you get hoarseness or a problem with your voice fitness syndrome, and our questionnaire picks that up. So this is a simple thing. The patient does it before you see them. You give them that, and then you fill it out, and you don't have to waste time in the consultation. You don't have to ask them about voice change, because they answer 0 to it. So it's a very simple thing. I use it every day in my clinic, and it tells me when people are severely compromised by this airway reflux, right? Or whether perhaps it's not the right diagnosis, but it rarely is wrong. Over 14 is the upper limit of normal. You'll get people scoring 60 or 70. So airway reflux is not what I mean. What happens to it? It lands on the epithelium. And when it does that, it lands on the epithelium, and the epithelium secretes things. They're called alarmins, right? It says, I'm damaged, right? And you can have an eosinophilic infiltration, so mimicking asthma. This is late onset asthma. You have a neutrophilic inflammation causing a bronchitis or bronchiectasis. But for us, it's all about the nerve. The nerve is irritated by ATP. So you have the central mechanism. What happens is the epithelium on the left there gets damaged. It's a release of ATP, which I will call connexin, and it lands on the end of the nerves and irritates them through P2X2 and P2X2/3 receptors. And this is a guy who discovered this system. It's called Jeff Bernstock. This is a photo I took of him at the British Pharmacological Society, and he's just telling me he's going to win a Nobel Prize. But unfortunately, he died before he won his Nobel Prize. But nonetheless, what he discovered, there is cell damage on the epithelium. It gives off alarmins. Some of them are very important in asthma, but these ones increase the sensitivity of the nerves via this P2X3 receptor. And here's a trial of gefapixant, a drug which is coming in about 2 years' time. Gefapixant blocks this P2X3 receptor, and you can see on the right there the effect of gefapixant versus the placebo on the left. And I've done lots of studies with these drugs, P2X3 antagonists. They're going to revolutionize respiratory medicine because they're going to tackle the major symptom caused by the sensitivity of the vagus nerve. So there's phase 2 trials there. You can see most of them are women. Patients that we see in the top clinic, and the Bellis as a tracking drug, the bottom one. And so we had 2,000 patients in these 2 trials. These are the phase 3 trials of gefapixant done by Merck. And they did the heart questionnaire, which I've been talking about, and the average score in 2,000 patients with this disease of chronic cough, right, was 40. Normal and normal range is normally 14. Okay, so this questionnaire picks out the patients with chronic cough hypersensitivity syndrome. So this is one disease. This is an elephant. This is the elephant called airway reflux, and it causes cough. And these are the actual results. The problem with the study was they went the cough counting as the primary endpoint, and that's got a big placebo effect. Okay, it looks impressive. But the bottom line here is that gefapixant 45 milligrams PD, you got 2/3 of patients better. It was a dramatic effect, and when this drug was licensed, and there are 3 others in the pipeline coming through, when these drugs are licensed, they will revolutionize treatment of respiratory disease. We will be able to treat symptoms safely and effectively. So how to diagnose your chronic cough? The patient comes along, I've been coughing for 18 months, do a chest x-ray, look for blood eosinophilia because they may have an Asthma type syndrome, do the heart questionnaire, and that's all you need to do. You can tell them you've got the disease of chronic cough. Okay, I'm done.
Thank you very much, Professor Morice. This is excellent presentation. We learned a lot. We have some questions. Mansoor, if you want to.
Yeah, that's fine. Thank you very much, Professor Morice. That was amazing. I think I just remember now, I may have actually worked with you when I was a renal registrar in Hull. That goes back almost about 10, 15 years ago. So I may have actually covered your wards or may have seen you doing on calls if you had done HRI, because I know respiratory used to be at Castle Hill Hospital. So
I'm on tomorrow morning.
All right,
HRI.
Yeah, so I used to work for. I used to work. I'm on call tomorrow. So I used to work for Professor Bandari. I know he's still there as well. Okay, so thank you very much for the talk once again. I've got a question, so I'll start with the questions from Professor Naqvi, my colleague. In patients with chronic cough and normal spirometry and peak flows, GPs usually go along the lines of reflux and other non-respiratory causes as underlying diagnosis. Is this the right approach, Professor?
Yeah, well, it is reflux, but it's not acid reflux.
Mm-hmm, mm-hmm.
Right?
Okay.
So don't give them PPIs.
Yes.
Right? PPIs do not treat reflux. Right? They block acid brilliantly, but the patient refluxes back up just as much. So this non-acid reflux lands on the epithelium in the delicate airway epithelium and damages it, and that releases the ATP, which causes this irritation. So reflux is not, acid reflux is treated brilliantly with PPIs. I took one this morning. They are great, but they do not stop reflux. If you need to try stopping the reflux, you need to give pro-motility agents. I use metoclopramide, domperidone, but particularly azithromycin. Azithromycin doesn't act as an anti-inflammatory. What it does is improve motility. It's an agonist of the hormone motility and produces increased movement in the esophagus. And indeed, when we look at these ladies who have this disease, 75% of them have esophageal dysmotility when we measure it in the esophageal lab. So it's a disease of the movement of the esophagus, I think, fundamentally.
Okay, thank you very much. Thanks. Another question from Naseem, Professor Naqvi. Can dextromethorphans-like antitussives be used long-term for refractory cough of unknown etiology? So basically, Naseem is talking about dextromethorphans, antitussives.
Yeah, dextromethorphan has a license for acute cough, right? So it's something you can get over the counter. And indeed, I have taken it myself when I've had a nasty viral cough. I think the major effect of cough linctuses, though, are actually the demulcent effect, which actually coats the irritant receptors. So the disease is, hypersensitivity. You coat the receptors with I use honey and lemon, and it does coat these receptors. We've shown it actually. I don't want to go into the biochemistry, but it binds to the receptors, right? The honey. So it's a useful thing, but if you're going to treat chronic cough, low-dose opiates at a steady state are the way to do it if it works. So you give MSD 5 milligrams BD, and it either works or it doesn't.
Okay, thank you. Another question from Pramod Suman, who asks, how about use of powdered steroids in unexplained chronic cough treatment? Powdered steroids in unexplained chronic cough treatment.
I'm not sure what you mean by powdered steroids, but steroid inhaled powder. So unfortunately, in the older people who get this chronic cough, because it's mainly middle-aged ladies who get it, very few of them respond to inhaled steroids. So either, what I do is I look at the full blood count and look at an eosinophil count, right? And if the eosinophil count is above 0.3, then I will give steroids a go. Right? But what I do is I give them 5 days worth of steroids. Right? And if they say, this is just tremendous, doctor, my cough has gone completely, right? I am fantastic. Then you can be confident that this is a steroid-responsive disease. Because in about 20% of the patients with a chronic cough, they get an eosinophilic bronchitis. And that responds to the steroids. So a short course trial of steroids is the best way to differentiate the diagnosis.
Really useful, thank you. Another question from Aravind Punusami, who asks, how useful is fractional excretion of nitric oxide fractional exhale nitric oxide test?
Yeah, FeNO. Yeah.
FeNO in ruling in or ruling out. Yeah.
No, it's not very good.
No.
So I don't use FeNO. We do it, but if it's really high, then that helps. But the review we did for the European Respiratory Society guidelines showed that it's not as good as asthma, right? Because this eosinophilic bronchitis is slightly different from ordinary asthma. Right? The eosinophils are in different bits of the lung.
True. I think we have already answered this question about what prokinetic can be used for long term, especially with restricted use of domperidone. So I think you've
No,
already.
it's not restricted.
No, okay.
No. All right, but there's metoclopramide has had an MHRA warning.
Warning, yes.
And domperidone has, and azithromycin. Anyway, all drugs have side effects, right? We're not treating here their licensed use, which is about relief of short-term nausea and vomiting, right? Or in azithromycin's case, treatment of bacterial infections. We're using them for different things, right? And provided we can justify that use, we are prescribing correctly.
Okay. Excellent, thank you. I think one last question before.
I think Mansoor, Dr. Aziz want to make some comment.
Okay, excellent. Yeah, okay.
I was just going to say that as Alyn was saying, that a lot of the cough is due to the upper airways and exhaled nitric oxide. I'm talking about Arvind's question that exhaled nitric oxide is more for lung inflammation, while as Alyn has very clearly stated, most of these chronic cough is from the irritation of the mucosa around the larynx. So that is not the area that produces nitric oxide. But if as again Alyn said, that if the eosinophil count is high, then it is possible that the chronic cough could be due to an asthma. When I mean, for the people who are in the forum, I would just say that I did work with Alyn.
No, Imran. The chronic cough is due to the disease of chronic cough. It may have an asthmatic component.
Yeah.
It is not due to asthma. It is chronic cough as a disease, right? Okay. And so then it might have an asthmatic component, whatever asthma is.
So well, that's what I'm saying, that when I worked with Alyn, we did produce a paper which did show that if you go step by step, there are some patients, but it was a small number where asthma was the cause of chronic cough, because
no, sorry, they have a chronic cough. The disease of chronic. You're looking at it the wrong way around, Imran. Right? There is a disease of chronic cough. Right? Yeah. This disease sometimes has some asthmatic components, right? The disease is not due to chronic to asthma, right? It is a disease in itself, right?
Yeah. So a very few number will either benefit from inhaled steroids or benefit from
they have chronic cough, which has an asthmatic component to it.
Okay. Thank you. I think one last question from Shahid Farouk, Prof. And the question is there no role of PPIs at all whatsoever in reflux cough, where it is actually in patients with high BMIs or asthmatic patients? Is there no role of PPI in your experience?
Yeah. Okay. So PPIs do not treat reflux. They are brilliant at blocking acid. So if the patient has acid-related symptoms, if they have severe heartburn, I give them the PPIs, right? Absolutely. And there is some evidence that they might help a little bit in the cough, but it's really very marginal stuff. So, the important thing is, if you've got acid-related symptoms, treat them. Yes, absolutely treat them. But it doesn't help the cough.
That's the point that we need to actually take home. So it doesn't treat the cough. If you've got symptoms of acid reflux, treat them with PPI. Do not treat them with PPI. Excellent. Thank you very much. I think that's the questions. There's so many questions, but we just with time, we can't really go through all of them. But I think I've tried to cover as many as I can. Naseem, have you got any more?
One question. Yes, I think one question for Dr. Aziz. Quick one. Is eosinophil count specific or sensitive for asthma? Is it something that we do routinely or not?
I do, yes.
Okay.
I check eosinophil counts all the time. with my main job being an asthma person, and although I do cover COPD, but asthma is my main love. So eosinophil count is literally the first thing we do. Because amongst other things, you need to remember that asthma is a disease which, just like if you have a person who comes in and you find that hemoglobin A1C is 54 or something like that, you will say that is diabetes. Asthma does not have a single test. It's some basic things that you can find in history, very little in examination, then you have the testing, and sometimes we have to give a therapeutic trial to come to a diagnosis, right? So eosinophil count is very important in coming to the diagnosis of asthma. And obviously the eosinophil count is also very good in if somebody has severe disease. And I'm talking about asthma, I'm not talking about cough. Severe asthma, where they have eosinophilia, now we have biological therapies that can be used for these. I have noticed that there is a question, or if eosinophil count is normal, can it rule out asthma? No, it does not rule out asthma. It is high eosinophil count points towards asthma, but you can have people who have high eosinophil count and they do not have asthma, and the people with asthma who do not have high eosinophil count.
Imran, I just want to let you know, actually, I always get excited as a renal physician when I see high eosinophil count in someone's got AKI, and I really worry about check straws and worry about vasculitis. So how often do you see that sort of overlapping in your asthmatic patients who may develop sort of AKI and then may have check straws or kind of EPGA basically?
Very rarely.
Really?
We do think about it all the time.
Same here.
So we all want to have, oh, I diagnosed GPA or EGPA, and it looks very nice because it takes you away from your every day-to-day mundane people. But we very rarely find it. I think I think both of these diseases combined, I think I have less than 10 people that I follow up.
Okay, thank you. That's really helpful. Naseem, do you want to conclude? Thank you.
No, you can conclude. I think we'll be back in September then. Summer break.
Yeah. No, thank you very much, Professor Alyn, Morice, and Imran, who've been really attending our webinar right from day one when we started in 2017, way before COVID. I think we started as actually a small, sort of webinar just mainly for educating each other and our classmates, and it's just gone global now. But thank you very much for both of you, and literally I could have actually learned a lot from today's talk. Just for everyone else, we haven't got any more talks for the next 2 months, just kind of actually with summer break and everything else that's going on. So we will resume in September. So please do come forward if you want to present or have got anyone else that could actually come and join us as presenters. So we would look forward to hearing from you. But thank you very much, and thanks, and have a good evening. And Prof, good week ahead, and you're all down for tomorrow morning. Thank you very much. Take care.
Bye-bye. Bye-bye.
Thank you.
Bye-bye.